Okay, so we're going to go ahead and get started. So this is going to be your guys' third exam for complex health. This portion of the semester really covers a lot about excretion, fluid electrolyte issues, renal issues, big picture of how we care for patients who are having a little bit of a problem with their kidneys. And I always like to start, our main function of our kidneys is they help detox our body. Not only do they help manage our blood pressure, but they help really the body get rid of everything. Even the foods that we eat, the water that we drink, the medications that we take, largely are managed and excreted by our kidneys. So a big portion of this review is going to cover a lot of our patient education on how we can help preserve kidney function in our patients, really what we want to look for, modalities of treatment, and really our goal is to prevent that end-stage renal disease. We don't want it to get to that point where they are no longer peeing, they are no longer excreting. So we want to educate the importance of taking care of their bodies. Because as we'll discuss later, our kidneys are very, very important, and if they no longer function, we need to somehow replace the kidneys, whether it be through transplant or dialysis, etc. But we will go ahead and get to it. So starting off just with a little bit of excretion. If I can find my mouse. Perfect. So the first thing we're going to talk about is BPH. BPH is our benign prostatic hyperplasia of the prostate gland. So really our main issue with this is excretion. As the prostate continues to undergo hyperplasia, it's going to increase in cell size. And unfortunately, as it increases in cell size, it's going to end up constricting the urethra, which leads to all of our pee, all of our fluid not being properly excreted. And it can be quite uncomfortable and sometimes really frustrating or embarrassing for these patients. So main concern is this bladder outlet obstruction. They are not able to fully void sometimes, or they might have really no control of if they can void or not. A big issue with this is our overflow incontinence. So what is this? It's just dribbling. So the patient may feel that they had stopped urinating, but they still might be producing a little bit of urine. So sometimes these patients might require like padding or diapers or anything like that just to help maintain skin integrity. Unfortunately, though, we have quite a few complications with this. And the reason that there are many complications with BPH is, think about it, we are not able to fully excrete. So there's some sort of backup, there's some sort of blockage. So what is my patient at risk for? They're at risk for UTIs, kidney damage, hydronephrosis. That's when that urine isn't able to go all the way out and it ends up backing up all the way through the nephrons. And it can even get as bad up into the glomeruli, etc. So we have quite a few risk factors. A big one for this is in any sort of increase in testosterone is going to cause that increase in BPH. And unfortunately, this is just common with our older male population. So what are these patients really going to present with? They might have a hard time starting their stream, and they might have a hard time finishing their stream, which leads to that dribbling, etc. They might feel that although they went to the bathroom, that they still could go, but simply can't, which can really lead to that bladder distension. So, what types of, if these patients are already predisposed to any sort of bladder distension or urinary retention, what would we want to avoid with these patients if they're already having a hard time going to the bathroom? What do you guys think? Feel free to pop it in the chat.
We don't want to put like a catheter through the urethra.
So we might actually be able to put a catheter in the urethra, but that's a really good point. If we notice that if we're putting in a catheter and we've kind of hit a roadblock or a blockage, we're not going to want to try to mess with that. We're going to want to get a urology consult. So that's a very good point. You went in, you put a catheter in, it wouldn't go in all the way. Do we keep trying to force our way in? No, we're going to need urology for that one. Are there any sort of medications we think would be contraindicated in this population? I know we just had our cardiac pharmacology exam. What medications would I maybe not want to give this patient if I know that they're already having issues with urinary retention?
Diuretics.
Diuretics actually help with the urinary retention. So we would probably want to get some diuretics on these patients. Is there any drug we learned about that causes the dries, that dry you up? The 4 dries. Can't see, can't pee, can't spit, can't poop. Those are our anticholinergic drugs. So anticholinergic drugs are actually going to be contraindicated in this population. So if you're caring for a patient with BPH and you notice that they're on an anticholinergic medication, we're probably going to want to hold that medication and consult the provider, just because that's going to lead to bladder distension, urinary retention. These patients already have such a hard time with excretion. We don't want to make it harder for them. So in order to diagnose this, we really want to look at their PSA levels. Usually they're going to be higher than 2.5. Additionally, this can be diagnosed via a digital exam. And what we can actually do with that is, after examination, if there was fluid, we're going to want to get a culture and sensitivity on that fluid to look for anything. But really, our PSA levels are going to be pretty important to look at. So what types of medications are we going to give these patients? We can give them tamsulosin to help kind of relax everything, make it a little bit easier. This is because tamsulosin is an alpha blocking agent, and it's just going to help promote relaxation. Finasteride can help with blocking DHT, possibly help shrink the prostate, etc. It does take a little bit of a long time to work, though. There's tons of minimally invasive options for these patients, but really what we're going to focus on is like the TURP, which is a pretty big surgery for these patients. And then after surgery, post-op, they're going to need continuous irrigation via a catheter. So it's super important that if your patient has BPH and they underwent a TURP procedure, that we really want to monitor what is the output, are they bleeding, are they still able to go ahead and urinate? Is there a blockage? Are there kinks in the tubing? So PSA is suggestive, not diagnostic. So it is definitely suggestive. Usually you're going to need the PSA in combination with that digital exam. So when it comes to patient education, we talked about avoiding the anticholinergic drugs. These patients might also simply need bladder training because they're not used to going all the time. A big one, what we want to do is promote skin integrity. If they're constantly dribbling, having incontinence, that can lead to skin breakdown. So like I said a little bit earlier, padding, diapers, etc. can help. And then I put sex with a question mark. So do we want these patients to be sexually active, to be having sex? Well, actually, sex can help drain the prostate, and it can help with some of the obstructive signs and symptoms. So when we're giving our patient education, we want to include their partner in this to see if they can help. So just to recap, BPH, really, how are we going to manage it? And I would review just kind of your post-op interventions. And I do have a couple of practice questions on that as well. So when we talk about an uncomplicated UTI, this is not a structural issue. Most common causes are going to be bacteria, viral infection, fungal infections, etc. Other causes can be feminine hygiene products, perfumes, douches, wet swimsuits, etc. So really educating how we can prevent UTIs is a big one for this. A major complication of UTIs is going to be bladder distension. These patients will produce minimal output. And then as nurses, if we ever suspect a UTI, we really want to go ahead and get a clean catch urine sample. So I would go ahead and review the proper technique for that, where they wipe, they pee a little bit, place the cup under their stream, and then making sure nothing's touching the cup, have them pee a little bit more than halfway, remove the cup, etc. We always want to get a culture and sensitivity before giving antibiotics. If we are still waiting on that CNS, we can give them some broad spectrum antibiotics in the meantime. But for these, really our main cause is E. coli. Why? E. coli is found in the poop, and it's more common with our females simply because of the proximity of the urethra to the uranus. Another big cause of UTIs is actually our CAUTIs, our catheter-associated UTIs. This is why it's very important to make sure we maintain sterile procedure when we're putting in catheters. It's also why we advocate our patients get their catheters removed as soon as we possibly can. We don't want a catheter staying in for a very long time. With these patients, though, again, similar to our BPH, our main complications with these is that bladder distension. But if we know that this, we want to make sure that it doesn't spread, that the patient doesn't become septic. So we really want to go ahead and make sure our patient is okay and that they get treated while it's still a lower UTI, because we don't want it progressing into the upper into the upper urinary tract. Again, signs and symptoms, really dysuria is very common. That's that pain associated with peeing. They might have cloudy urine with an odd odor. Usually that flank back pain is also pretty common. A big one is going to be our confusion in the elderly. If you've had a patient on your floor that's of increased age and all of a sudden her mental status just isn't there, she's not remembering things, she might be a little bit combative, I'm probably going to want to do a clean catch urine sample just to make sure she doesn't have a UTI. Other lab values that are really important is positive leukocyte and nitrates in that urinalysis. Sorry, I'm trying to go to the next slide, but Teams has just not been too great today. Oops. So how are we going to treat it? After getting our culture and sensitivity, we're going to want to give antibiotics. Really common is going to be your TMP, SMX. So I would just review some side effects associated with our antibiotics. For pain, we can give them a pyridine. One thing about our pyridines, though, is that they can turn the urine orange. So you are going to want to educate your patient that if they're prescribed a pyridine, that their urine might be orange. That way they're not anxious, they're not freaking out, they're not going to the ER. Just make sure you include that in their education. And really promoting kind of a healthy GU system on these patients. We want to teach them wipe front to back, drink lots of water. Cranberry juice can be used as a pretty good prophylactic, not necessarily to treat a UTI though. And then really avoid some irritants. Alcohol and caffeine can be a pretty big irritant. And then most importantly, just go when you have to go. So I would also review how to prevent your CAUTIs. They're a big issue in hospitals. So I do have a practice question for you guys. So this is part of the next generation NCLEX. Now I know you haven't got too much exposure yet, but as kind of the semester and the course progresses, you're going to make this transition. I also like including these next gen NCLEX practice questions because I feel like they really dive a little bit deeper into disease process, and I think there's a lot to learn from this. So in this question, an 80-year-old woman was admitted to the hospital after an episode of acute confusion. She does have a history of diabetes, but no dementia or confusion. They live alone with their with their spouse and their son. The nurse documents these findings as part of the shift assessment. What assessment findings require follow-up by the nurse? So you have all of your assessments done on the right. As a nurse, if you saw this in the patient's chart, what would you want to follow up with? Feel free to pop in the chat. I'll give you a little bit, and then we can go one by one. Awesome job, guys. And here are the answers. So we want to check our patient's temperature. She's running a little bit of a pretty low fever, but I'm still concerned. Heart rate, it's still a regular, it's within normal limits. Same thing with our respirations, again, within normal limits. The urgency, I'd want to follow up on that, especially the pain and urination. She is pretty fatigued, so I would want to assess just to make sure that this infection hasn't spread too much. Also, I'm going to want to check for glucose in the urine, and then that CVA tenderness. If we think back to health assessment, if we have UTI, usually they're going to have that pain in that CVA area. What do you guys think about glucose in the urine? Why, like, what do we think about that? Why do you guys think that might be something I'm concerned about? She does have a history of diabetes mellitus. How can we link, kind of putting it all together, how can we link patients with diabetes to patients that have frequent infections? So we're not at DKA where the kidneys can't filter at all yet. Awesome, very good. So diabetes does make them more prone to infection, especially if the patients are excreting glucose through the urine. Bacteria absolutely love sugar. So if a lot of sugar is being excreted through the urine, especially with some of our oral anti-diabetic drugs, that is an absolute breeding ground for bacteria. So just keep that in mind. Does that make sense? I have another practice question for you guys. Why is a respiratory rate of 22 normal? It's just going to be within that normal limit. And even if it might be a little bit high, is the patient symptomatic? Are we noticing a trend? So if you ever look at your lab values and they're kind of teetering a little bit within that slightly elevated, are they symptomatic? So why do we want to avoid cranberry juice with interstitial cystitis? It's just because it can aggravate the interstitium with that one. Because instead of it being like more of a urethra problem, it's more on the inside. So we kind of want to avoid that because it might be an irritant. So I have another question. This is one of our select all that apply questions. So if I'm providing patient education to a female with cystitis, what do I want to include? Good job, guys. So we want to increase those fluids. We want to make sure that they take all of their antibiotics. We don't want any antibiotic resistant bacteria being developed from this. If the urine still remains cloudy, we want to call the clinic. This infection should clear up. If it's still cloudy, they might need to be put on a different antibiotic. Also, remember our sulfa drugs, we need to practice safe sun. So put on sunscreen, wear long sleeve clothes, hats, etc. And avoid those spicy foods because it can cause further pain and irritation. So I have a next one. Which of the following lab tests resorts the diagnosis? If my patient thinks that they have a UTI. So it's asking about UTIs. Which of the following lab tests support that their diagnosis is right, that this is a UTI? So a good way to kind of tackle these questions is what's related to this? So for example, G, negative ketones. Do ketones have anything to do with UTIs? No. Ketones are very specific to diabetic ketoacidosis. So really unrelated. So we're going to kind of skip over that. So the answers for these are A, D, E, and F. All right, and one more question kind of on this excretion. This one is about BPH. So my client is recovering from that TURP procedure. What are some things that I would need to implement? So this one can be a little bit difficult, so we'll kind of go one by one. But if my patient is recovering from TURP, and I want to, if you ever see potential post-op complications, what it's asking you, how can I prevent this? How will I prevent this? So falling, how can we prevent falls for a patient that's just had a TURP procedure? Remember, TURPs, they involve continuous irrigation catheters. What do we want to do for that one? We want to make sure that we secure the catheter tubes. Remember, we place it on the patient's thigh. That way they're not hanging out and they could trip. When we talk about hemorrhage, how can we prevent? How might we want to prevent a hemorrhage in these patients? In regards to their TURP procedures.
The vitals.
Vitals could be an answer choice. What do you think? A lot of these questions are like, what's the best? So correct, but not most correct, if that makes sense. We really want to monitor their urinary output. We want to really make sure that there's not lots of blood, that it isn't red, it's not indicating any sort of bleed that could eventually progress to a hemorrhage. What about infection? Infection would be our vitals. Those early signs of infection, that tachycardia. Awesome. What about obstruction? What is something we can do to prevent obstruction? And this can go for any sort of tubing device, whether it be IV, NG tube. we want to make sure that we monitor the tubing, make sure there's no kinks in the tubing. And then finally for pain, what can we do for managing pain, especially with these types of surgeries? Anything involving like the bladder or the urinary system, we're going to give an antispasmodic. So I also included this slide with some rationales for you guys to review. All right, so we're going to talk about kidney dysfunction now. The first thing we're going to talk about is our PKD, our polycystic kidney disease. So essentially, this is a genetic disease, so it's inherited. There's two types. We have our dominant, which is our more common disease, usually progresses as the patients get older around age 30. If someone inherits a recessive form of this and the recessive trait, this usually presents at birth and unfortunately leads to an earlier death. So what's our risk factors? Genetics. We want to encourage family testing, etc. While this is a pretty livable condition for the dominant trait, it does have some pretty big complications. So these cysts can be painful, they can get infected, etc. But think about it, if you have all of this buildup and these masses forming on our kidneys aren't going to be able to filter as well. Additionally, if they can't filter, it might lead to hypertension, simply because the kidneys help control our blood pressure. And if my kidneys aren't working very well, I'm probably going to have a hard time managing my blood pressure. So our signs and symptoms, you might actually be able to palpate and feel their kidney. They also might have some hyperfiltration progressing to oliguria because they're just not going to be filtering as effectively. Our lab values are pretty standard for any sort of kidney issues where you kind of have that increased BUN and creatinine, but that decrease in GFR. We're also finding things in the urine that we usually don't find. We don't find protein in the urine. We don't find blood in the urine, etc. So as nurses, we really want to make sure that although we are managing their pain, because this can be painful, we don't want to further put any more harm or stress on the kidneys. Therefore, we really want to be careful and pretty much not give them any NSAIDs. Give them alternatives instead, such as dry heat, relaxation, distractions, some complementary and alternative methods to help manage the pain. If they do have infection, we can manage that with some antibiotics. Just make sure that you review if we're giving our CPRO. Monitor for that tendon rupture, those eye problems. Remember our Floxin drugs, tendons to the floor, monitor they might have arm or tendon or leg, ankle, Achilles tendon pain. And then, of course, with our TMP, SMX, Safe Sun. They can also have needle aspirations for these cysts, but a really big takeaway for this is managing their hypertension. Again, we don't want to put more stress on the kidneys than we have to because they're not functioning as effectively. So again, similar to our renal diet for the patient's education. And then really daily ways. If my kidneys aren't filtering, they could potentially be holding on to a lot of fluid. And if they're holding on to a lot of fluid, they're holding on to a lot of electrolytes. So we might have some imbalances. So daily ways are the most accurate way of monitoring for fluid retention. Not INO, not blood pressure, daily ways. And even if your patient might not want to go on the scale, are your shoes tight? Have your clothes not been fitting? Is your wedding ring no longer able to go on or off? Is your jewelry, is your watch tight? Are you having difficulties putting your socks on? All signs and symptoms of fluid overload. So now we're going to talk about CKD. This is a really heavy hitter when it comes to testable material. And I really like to kind of break this up and kind of do a little case study with you guys. So with our chronic kidney disease, really, it's a chronic disease. It occurs over time. You have 5 different stages of kidney failure, kidney disease. when we're in those stages 1 through 4, my kidneys can still function. Not great, but they can still function. Therefore, our main concern for those early stages is going to be educating my patient on how to preserve kidney function, how to stop the progression. We can't reverse, but we can stop and slow the progression. And what are some risk factors? So that's really what we're going to focus on for that early kidney disease. But unfortunately, if our patient doesn't follow through, or maybe they haven't been diagnosed and they progress to end-stage renal failure or end-stage renal disease, that's when we're now going to need to treat. So don't pay too much attention to our GFRs. However, I would highlight that when we are in end-stage renal disease, we have a GFR less than 15. At this point, the kidneys are non-functional. Your patient will not be producing urine anymore. They simply won't be peeing. Therefore, if they're not peeing, they are not excreting. So really, at these 1 through 4, we're focusing on educating, making sure that they are aware of the risk factors, slowing progression, etc. But unfortunately, once they get in that 5th stage, they're going to have anuria. I have listed a couple complications, so just to review those, especially your renal osteodystrophy, etc. And just what are our complications with end-stage renal disease? Think about fluid overload. We can no longer excrete. Everything is building up in the blood. The food we eat, the water we drink, the drugs we take, all of that is staying in the system, which can lead to toxicity. Pay attention to a few of your lab values. Really, when you're in that end-stage renal disease, the azotemia, that's when you have blood protein, creatine, and BUN all increasing in the blood. You're going to have that NH buildup. These patients will be at risk for metabolic acidosis. So if you get an ABG on them, you're most likely going to see metabolic acidosis where their pH is very low and their bicarb is too low as well. And really how our end-stage renal disease is diagnosed with that estimated glomerular filtration rate. So what can we do? Well, in stages 1 through 4, we really want to focus on helping our kidneys out. They're having a hard time. We need to support them. So in 1 through 4, we're going to support the kidneys. So how do we do that? Giving diuretics, phosphate binders for meals. Remember, if my patient is receiving a phosphate binder, it has to be taken with meals. That's the whole purpose of a phosphate binder. It allows you to eat food that has phosphate in it, and it allows your body to help digest it while still keeping those levels low. If you don't take it with food, it's going to serve no purpose. We're also going to want to give them some supplements just because a lot of our foods that are unfortunately restricted with these cases have lots of important vitamins, nutrients, etc. So we still want to make sure that they're okay. Again, monitoring that blood pressure as best we can, etc. Also, remember our E alpha, when would we hold that? So just review your erythropoietin alpha. As nurses, really pay attention to your patient's lab values, especially our potassium and our calcium. If my patient is severely hyperkalemic in the 7s, hemodialysis is almost always going to be ordered rapid. Again, fluid overload is a big one. We'll talk about nutrition in a little bit, but even though we are restricting, we still want to make sure our patient receives adequate nutrition. So a good way to do that is to look at their albumin levels. And again, how can we help support the kidneys? Daily ways, renal diet, etc. Again, I included this sign, the Chauvet sign and the Trousseau sign, just kind of review what each of those are. They're what we're going to do if my patient has like a calcium imbalance, which is common with this renal osteodystrophy. These are what the assessments you would do for them are. Again, I included another photo just of all the complications of CKD. I have another practice question for you guys. A 52-year-old female client was admitted to a med-surg unit with fever, hematuria, and abdominal pain. The client has a long history of PKD. Of all the following, is it indicated, contraindicated, or non-essential? I'll give you guys a minute, and then I'll give you guys the answers. The big difference here, I get a lot of questions on what's the difference between contraindicated and non-essential. Contraindicated means due to this disease process, we want to avoid doing this action. Whereas non-essential simply means this action is not related to the diagnosis right now. If my patient is, I don't know, maybe they're coding or something like that, probably don't want to do an AccuCheck right now. Even if they are a diabetic, that's not related to what's happening right now. So just keep that in mind when you see questions like this. So in this situation, we have PKD. We have swollen, inflamed, aggravated cyst on the kidneys. We do not want to palpate. That's going to cause lots of discomfort and complications. I do, however, want to consult dietary. Why? Again, support these kidneys. How can we do that? A nice, healthy diet. Again, contraindicated NSAIDs. They are toxic to the kidneys, totally against the supporting the kidneys. We do want to encourage some fluid intake. For these patients, we want to make sure that they're not dehydrated. Make it a little bit easier for the body to, again, excrete. We do want to follow up on a family history of this disease. And right now, blood glucose levels are not pertinent. So let's talk about managing kidney failure. We just talked about our chronic kidney failure, which unfortunately is a chronic disease that involves progression. So what happens if our chronic kidney disease progresses so bad they are in end-stage renal disease with that GFR less than 15? They are not peeing and they are not excreting. Their kidneys are non-functional. Well, now we need to essentially do what the kidneys do. We have technically three things that can happen. Number one, we could do dialysis. We can do peritoneal, or we can do hemodialysis. Or they can receive a transplant because their kidneys are irreversibly damaged. They might as well have no kidneys. So, how do we manage this? Well, up first is kind of the preferred method of dialysis, our peritoneal dialysis. This allows for a lot more flexibility. These patients can do it in the comfort of their own home. We can train them for about 3 to 7 days of training so that they can go home and do it themselves. A big thing I always want to hit on is who's the kidney in this situation? Well, in this situation, it's going to be our sugar dialysate. That is what's going to go into the body and pull out those small molecules, that potassium, sodium, protein, etc. So in peritoneal dialysis, what's acting as the kidney, what's acting as the filtration system? Our dialysate. So just keep in mind that peritoneal dialysis involves a sugar dialysate. Kind of review your inflow, your dwell, and your drain. Again, no matter what you're doing, when you're doing it, this is a sterile procedure. Why? They have a catheter placed into their abdomen. Bacteria can get in and it can get into the body pretty easily, which is why this needs to be done sterilely. And this catheter is usually placed during surgery or at the bedside. Again, if I were to review your notes, go back and review the different types, those intermittent, ambulatory, continuous cycling, automated, etc. But a few points. During inflow, it might be a little bit uncomfortable. They are getting 2 liters of fluid pushed into their stomach. If they're uncomfortable, we can slow it down a little bit. So we need to put that in their stomach, let it dwell for a little bit, let it do its job, and now it's time to drain. Again, this can be a little bit painful. We do want to make sure we get what went in, making sure we get it out, so you can help massage the area, change positions to promote drainage, etc. Again, pros, there's less rigid dietary restrictions. Why? They are able to get dialysis every single day. So just keep in mind, still restrictions, but to a lesser extent. Unfortunately, though, with using that sugar solution, we do want to be cognizant of hyperglycemia. So review those signs and symptoms, etc. Again, really making sure that we are doing this sterilely. If not, it can cause peritonitis. How do we assess for this? How do we assess for peritonitis? There's lots of things we can assess for. It's an infection. I see cloudy effluent, pain, fever, all good ones. Very good. Might be redness, swelling, etc. Very good. So main complication is our peritonitis. So let's say we had a patient in chronic kidney disease. They progressed to stage 5. Again, GFR less than 15. We gave them peritoneal dialysis. They did it for a little bit. We're slacking a little bit. Now they come to me with their drainage bag looking like this. Well, that's peritonitis. And unfortunately, if my patient gets peritonitis, they are showing us that they can't maintain sterility. So we're going to have to put them on hemodialysis. For patients who are diabetic, can you still administer insulin with peritoneal dialysis? Absolutely, you can. You might need to adjust some doses as well, and you might need to more frequently monitor, but absolutely, you can have insulin. Usually, though, our diabetic patients might not be candidates for this type. It's really up to the provider. So back to our little case study. My patient has peritonitis. We're going to remove the catheter and they're going to be put on hemodialysis. Because also, think about it, they have a massive infection, peritonitis. I'm going to have to give antibiotics. Antibiotics are also so hard on the kidneys. So it's just not very good. So if they get peritonitis, they're probably going to need, most likely 9 times out of 10, be switched to hemodialysis. So in this situation, what's acting as the kidneys? The dialyzer is acting as the kidneys. So essentially what happens is it takes blood from a vein, pulls it out, filters it, and shoots it back through an artery. So any patient on hemodialysis will at least have 2 things being placed in them, 2 catheters. We have temporary catheters that are great for instant use. But if your patient will be on long-term hemodialysis, they're going to need a permanent catheter in place, either your fistula or graft. So just review kind of the differences between a fistula and a graft. Both of these don't work instantly. You need to heal the area first. So although this will be placed during surgery, these patients will also need a temporary catheter in place. Always, whether we have a fistula or a graft, we need to palpate for thrill and auscultate for a bruit to make sure that that site is patent. Why? This procedure connected an artery and a vein together. So we have to do both assessments. If at any point you're a nurse and you have a patient that has this fistula or graft in and you no longer feel a thrill, or you do not hear a bruit, that is an immediate call to the provider because this catheter is no longer patent. It will not work. They will not be able to receive their dialysis through this. So they need to have that removed, have another one placed, and again, subsequently, we'll need to have a temporary catheter put in place as well. It's also why we make sure we never take a blood pressure in an arm of a patient who has their dialysis catheter in. So again, I did include some hemodialysis nursing considerations, so make sure to review these. There's a lot of contraindications for hemodialysis, mainly patients with hemodynamic instability. If they're already pretty unstable with unstable blood pressure, the last thing we want to do is take blood out because that's going to mess with their blood pressure even more. So those patients will be put on CRRT. Making sure that we have our heparin and our protamine sulfate is a big one. Bleeding precautions. Again, with that area where that grafter fistula is, monitoring for that Steele syndrome is also very important. We also want to hold our antihypertensives and our antibacterials before dialysis. Why do you think we would want to do this? Why would it be important? Let's just start with antibiotics. Why do we hold our antibiotics before dialysis? Yep, it will get filtered out. That infection's probably not going away. Awesome. What about our antihypertensives? Why would we want to hold those? Yep, dialysis can cause some hemodynamic instability. So I don't want to be giving them a blood pressure medication that could peak halfway through dialysis. Not good at all. If we do notice our patient starts to become hypotensive during dialysis, we can try to slow the rate at which it's going. But usually these patients will be on constant blood pressure monitoring, usually every 2 to 5 minutes. I also included some patient education and some complications, so just review that. And a big point to this one is these patients need to return to treatment. They're going to have it 3 times a week for 4 hours. This is why their dietary restrictions and their fluid restrictions are a lot more rigorous because they're not getting dialysis every day. So just keep that in mind. So I listed some of this here and we'll go into nutrition a little bit. But really, I can't stress this enough. The kidneys stop producing urine with a GFR less than 15. That is end-stage renal disease. Your kidneys aren't functioning anymore. Everything is building up. So now we have hyperkalemia, hypernatremia, all of that, which is not good. So I do have another practice question. The nurse is caring for a 54-year-old male client with CKD requiring hemodialysis. They have an AV fistula in the left arm with a history of diabetes and fibromyalgia. Again, another one of these complications. How are we going to prevent these potential complications? So how would we prevent hemorrhage in these patients? We had to give these patients heparin. So what can I do to prevent bleeds if I know my patient had heparin? That is one of these answer choices. Awesome, 2. We want to avoid some invasive procedures. Very good. What about hypotension? What can we do to prevent hypotension? Yep, we want to prepare to rehydrate with some IV fluids. Very good. What about for fever? What can we do for fever? What might fever be indicative of? So fever might be indicative of infection. So I'm going to want to get a blood culture to make sure they didn't get any sort of infection. Remember, hemodialysis is an invasive procedure. So yes, 5. What do we think about DDS, dialysis disequilibrium syndrome? I always like to connect DDS to donating blood. When we donate blood, we have a pint taken out. We don't get it put back in. That's why they have you stay there 5 to 10 minutes after. They ask you, do you have any headaches? How are you feeling? Get some vitals on you, etc. So essentially that happens pretty frequently with dialysis. Think about it. We're taking a lot out. We're putting a lot in. I also didn't talk about it much, but I did include on the slide some info about DDS, so make sure to review that. But for that one, we want to assess for nausea, vomiting, headache. Those are all cardinal signs and symptoms of DDS. And then pericardial disease. What do we want to do for this? I know we haven't talked too much about it, but we want to assess for a pericardial rub. I included, I did share the PowerPoint with you guys. This slide doesn't have the answers, but I did include it in the notes. So now we're going to talk about kidney transplant. So if my patient had kidney failure, kidney disease, end-stage renal disease, and they qualified for a transplant or had a family member willing to donate, they would possibly be eligible to have a kidney transplant. Now remember, kidney transplant is not a cure. They will still need to be making these lifestyle changes. So we kind of separated them into for you guys. Into the recipient and the donor. So I would just review your kidney transplant information. I'm not going to go too into detail with this. I would like to spend a little bit more time on nutrition. So just really review kind of what it takes to be a recipient, what it takes to be a donor, etc. Some of the exclusion criteria. Our histocompatibility studies are very important. I do want to hit on this with the cross-matching. A positive cross-match is not good. This means that there is an immune reaction, a positive immune reaction. A negative cross-match is good. We do not want an immune reaction. We want their cross-match test to be negative. Make sure that we also do this test again right before the transplant because there could possibly be a change in antibodies. So we really want to make sure that their cross-match test is A-OK. With our recipients, usually they don't remove the failed kidney. They leave it in unless it's causing pain, discomfort, etc. They're going to have to stay in the hospital for a little bit longer, whereas our donors can go home pretty quickly. However, these patients that received an organ are going to be on immunosuppressants for the rest of their lives. So really making sure that that education is there, that you're going to be on immunosuppressants. You are going to need to avoid crowds. Do not hang around sick people, masks, etc. So post-op for a kidney transplant, we really want to make sure that this patient has a Foley. Their urinary tract, their whole, everything is not used to producing urine. Remember we talked about it? They weren't producing. Now they have working kidneys. The kidneys might be a little bit confused. So we really want to make sure we monitor their output and make sure that a Foley has been placed in. If they have a very abrupt loss of urine, we're really concerned for rejection, etc. Again, monitoring their fluid and electrolyte balances is super important. Fluid loss may be even as high as 1 liter a day in the post-transplant. So whatever my patient is losing in fluids, we need to match it exactly. They lost a liter, we need to give a liter. Again, monitor for their fluid electrolyte imbalances. Daily weighs are so important. They're at risk for fluid overload if their transplanted kidney is not functioning. What do we think about our creatine? Do we think that post-op it might be low, it might be high? What do we think? It might drop initially. We really want to pay attention to trends. So it might plateau. It might go up, and then it might stay steady. That's fine, because we're seeing a trend that it is staying steady. What we don't want is a positive trend in the upward direction. This can indicate that the kidneys might be failing again. If we suspect a rejection in our patients, we want to increase immunosuppressants. Additionally, we're going to want to keep them calm because it might be scary that they just got this kidney and now they might lose it. So again, I would just spend a little bit time kind of reviewing your acute kidney failure, your chronic kidney failure, etc. That was talked about in your pre-class worksheet. So just review that. Again, we have a little photo of the hyperacute, the acute, the chronic, etc. Really medications for these patients, again, immunosuppressants, corticosteroids, etc. So knowing that we need to give that education that you're going to be on these drugs for life and you're going to need to do all of the things that an immunocompromised individual might do. And again, we're also going to talk about that a little bit with our HIV and AIDS patients in a little bit. But I would just take a note, really know each stage of the kidney transplant rejection. So before we begin nutrition, does anyone have any questions so far? If you do, pop them in the chat. Lainey's in the chat. She's awesome. She'll help answer your guys' questions. But we're going to talk about nutrition. Nutrition is a really big topic on this exam. ATI has some practice nutrition stuff if you're looking for practice questions. But really, we're going to break it down pretty basically. As nurses, we're responsible for making sure the patient has the correct diet in the hospital. Watch their meal trays. If you notice something on their tray is wrong, correct it. You might have questions that show you a photo of a meal tray, and you might have to make a decision. What do I want on? What do I want off? So just keep that in mind. Protein is restricted in these patients because increased protein leads to increased protein breakdown and waste in the body. Talked about this a little bit earlier, but we really want to measure our patients' pre-albumin levels. Why? We still want to make sure they're nourished. Again, sodium, we need to avoid sodium to prevent water retention and hypertension. Really, sodium, processed foods. We do not want processed foods. We don't want cans, fast food, chips, pretzels, pickles, ham, bacon, sausage, etc. We need to restrict potassium. Again, potassium pumps the heart. If we're not excreting potassium because we're not excreting anything through the urine, my patient might become hyperkalemic. This is also why, even though we're avoiding sodium, we want to avoid salt substitutes. Why? These contain sodium. And then phosphorus, as kidney function lowers, it can cause a buildup of phosphorus in the blood, which can actually cause our bones to get much, much weaker. So again, review our protein. But pretty much the general consensus of this is we want low, 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 everything. So let's break it down. Protein. Early protein restriction can actually benefit our early CKD patients and help prevent the progression. We do want to monitor our albumin levels. We want a nice sweet spot between 3.5 and 5, which is similar to potassium. So that's one less thing for you guys to have to memorize, but just making sure it's within that 3.5 to 5 range. Unfortunately, we want to restrict protein so these patients can have fruits, veggies, grains. We really don't want whole grains. We want regular grains, some cereals. Be careful with the fruits and the vegetables, just because they can contain higher amounts of other nutrients and water. But really avoid those red meats. If we want some protein, lean meats. Lean fish, lean chicken, etc. Pretty much avoid all milks and cheese as well. When we talk about potassium, really avoid those high potassium foods, those quote unquote creamy fruits, your bananas, your melons, your nectarines, your mango, your papaya, etc. Really for these patients, we want some berries and apples. Avoid those avocados, those broccolis, etc., especially spinach. Again, that nuts, seeds, etc. So really review these foods. Really focus on what we want to avoid and what we could possibly substitute it with. Again, sodium is pretty self-explanatory. No processed foods, fast foods, chips, pretzels, pickles, ham, bacon, sausage, anything that they could find in the pantry. Ideally, these patients want like a plant-based diet. Opting for fresh items, frozen vegetables, not canned vegetables, fresh seasoning, not those regular seasonings unless they specifically say like low sodium or no sodium. Really avoid the pantry for these patients. Also review how to assess for fluid overload. How do we assess for fluid overload? If I think my patient hasn't been following their sodium restrictions, daily weighs. I want to get their weight. And then we'll see how well they've been following this diet. Up next is like our phosphorus foods. Again, what are we avoiding? What are we substituting with? Why are we concerned? Back to that renal osteodystrophy. So a lot of content here, but we really want to avoid like those creams, meats, the Western diet, sugar, etc. I always say avoid your browns, whites, and tans. White referring to your milk and cream. We do want white rice. That's pretty much the only rice that they can have. But we do want to have light fruits and vegetables. Again, that water content, rice, yellow cake, regular grains. We do not want whole grains, regular grains. Crackers, popcorn with no salt, etc. So review your renal diet. Again, ATI has some good practice stuff as well. When we talk about cancer, we have two types of cancer, your benign versus your malignant. Again, both stemming from a defect in cellular proliferation. I did include the box from your pre-class worksheet. I would make sure that we know that our epithelial tissues are carcinomas, connective or your sarcomas, multiple myeloma, etc. Also, most of our malignant tumors end in that sarcoma. So just kind of reviewing how we're classifying it. No matter where cancer metastasizes, it's still classified by where it started. Really a big thing for cancer is going to be about our screening. So for women, we want to start getting mammograms at 45, and then we can get them biannually after age 55. Pap smears starting at 21 or whenever the female starts becoming sexually active. You're going to want to give them every 3 years. Colonoscopy every 10 years after 50, prostate exams, etc. Prevention, really diet, exercise, and avoiding carcinogens. I included for signs and symptoms, if you read it down the line, it actually spells caution. That's a good mnemonic I like to use. But just kind of really knowing if you have that odd mole, you're having just a sore that seems odd, etc., to go get those checked out. Our gold standard for determining if something is cancerous, malignant, benign, etc., is going to be our tumor biopsy. You can also look at some genetic markers. If we're concerned for like multiple myeloma, we can kind of do a bone marrow exam, etc. And then there's lots of complications associated with cancer. So when we're treating someone with cancer, we start out with prophylaxis. We want to prevent. If my patient gets diagnosed with cancer, we're going to try to cure it. If curing isn't an option, we're at least going to try to control it. And then finally, if that's not able to happen, we're going to focus on palliation and comfort care. But a lot of it's going to be your nursing considerations. So a lot of these patients will have mucositis. So how can we kind of help that? It might be painful, it might be uncomfortable. We can give them swishes, moisturizers, etc. Encourage them to use kind of a soft bristled toothbrush too. Major complications, and a lot of these are complications of treatment and chemotherapy, but that thrombocytopenia can actually be caused by certain types of bone marrow cancer. But really watching for bleeds because of that thrombocytopenia. What's our platelet levels we're concerned about? A little bit less than 100, that's when I get really scared. A big thing of bleeds is that rigid board-like abdomen. Pay attention to their vitals. If you see a steady increase in heart rate and their blood pressure keeps dropping a little bit, I'm concerned for bleeds. Adequate nutrition is a big one. This is the only time that we will ever tell these patients, you can eat whatever you want. These patients usually aren't hungry, they're malnourished, they're not eating. So if your patient asks you for ice cream, you're going to give them ice cream. If their family members bringing them some cultural foods from home, allow them to have it. The goal is food. A big thing with these patients is, again, immunosuppressants. So what do I teach? Do you guys, what are some things you would want to teach your patient on if they were on immunosuppressants? What do we think would be a good idea? Not just avoiding large crowds. What else might we want to teach them?
About maybe adverse effects or side effects. Is that what you're asking?
So when I talk about educating on immunosuppressants, if my patient goes home on an immunosuppressant drugs, what do I not want them doing? What would I want them to possibly look out for? So the side effects of immunosuppressants is they're a lot more likely to get sick. So what are some ways that I can keep these patients safe? Anything that would expose them to an infection. Do we want my patient gardening? What do we think about that?
Is it because of sun exposure?
Not the sun exposure, but farmers markets have a lot of opportunistic pathogens. So we don't want them, eating foods that haven't been thoroughly cleaned, like fresh out of the ground produce. Their bodies can't fight infection. So we definitely don't want them going to farmers markets. We don't want them gardening. There's lots of bacteria that to normal people are pretty harmless, but to someone that's immunosuppressed, it can be a really big deal. When we think about immunosuppression, not only are they more susceptible to the flu, but they're more susceptible to very rare diseases that simply we just don't get because our body's immune system is awesome and it's amazing, but with immunosuppressants, we no longer really have an immune system. So really, hygiene, avoiding farmers markets, avoiding kids, taking your temperature frequently, washing your toothbrush in the dishwasher with bleach, etc. Our two main things for cancer treatment is going to be our chemotherapy and our radiation. Again, I would just review differences between chemotherapy and radiation. Specifically, radiation, these patients' skin becomes photosensitive for a year. We don't want any, also prior to their radiation, avoid those lotions, harsh soaps, etc. And really review as a nurse, how do you keep you, your patient, and their family safe during these procedures? This is highly testable and bound to show up again. Lead gowns, forceps to move items, never touch anything with your bare hands. If you are pregnant or trying to conceive or plan on being pregnant, you do not want to be around radiation therapy as a nurse. And then just review your complications of chemo. What happens if my patient's getting chemo and now there's extravasation? What do I do? Always stop the infusion. So just really review some nursing considerations. So I do have some more practice questions. What do we think about these ones? And we might go a little bit over time, but I do want to work through these practice questions with you guys. So I have two practice questions and then some stuff about HIV and AIDS. So if my patient is undergoing chemotherapy and has immunosuppression, do I want her in a room with someone else or do I want her isolated? I want her isolated, so it would be contraindicated to place her in another room. Assessing the oral cavity. We talked about mucositis. Do you think it would be important to assess their oral cavity for mucositis? Yeah, it would definitely be important. I do want to monitor my patient's white blood cell count. I want to monitor that because they are at risk for leukopenia, thrombocytopenia. So really making sure that my patient still stays safe. Awesome job. Very good. I do not want to put in a Foley because we talked about Claudi's earlier, more chances for infection. Limiting the providers in the room, etc. So we do want to limit the providers in the room. Again, less people, less chance for infection, checking their temperature, etc. This is another one of these questions where we have to put in the nursing thing, the nursing action based on the complication. So I'll give you guys a moment, but how would we work with neutropenia? How would we, don't worry too much about the hypercalcemia. We haven't talked about chemotherapy drugs in pharmacology yet, so you can skip over that one. But the peripheral neuropathy, mucositis, thrombocytopenia. So here's some of the nursing actions. Neutropenia, you're going to administer this drug. Again, we'll talk about it a little bit more with cancer drugs and immunosuppressants. This drug actually does help with the neutropenia. It's frequently administered 24 hours after chemo to help prevent severe neutropenia. Hypercalcemia is a medical emergency. You can kind of think about it. We give calcium channel blockers to help with the heart rate. If we have oddities in our calcium levels, it's going to have a pretty big effect on the heart, which is why we need to take care of this. So really, fluid resuscitation is a big one. Fall precautions, peripheral neuropathy, they're having a difficult time feeling their feet after chemo and radiation and whatnot. So really, fall precautions are important. For mucositis, avoid smoking. That's further more going to irritate the mucosal membranes. And then thrombocytopenia, risk for bleeds. So I probably want to use the smallest needle we have. The last thing we're going to talk about is HIV and AIDS. Before we get started, a big thing to kind of keep in mind is HIV is simply the infection. Not everyone with an HIV infection will progress to AIDS. AIDS is a status, if you will, and we'll talk about it in a minute, but just keep that in mind. So again, HIV is going to be caused by that HIV infection, multiple modes of transmission, but it is transmitted via blood contact. So what happens with these patients is that HIV infects the bodies and it really attacks our body's CD4 cells, which are major cells involved in our immune line of defense. So with these patients, the lower the viral load, the safer the patient is with less symptoms. So we want to focus all of our treatment and our considerations on decreasing that viral load. A big one for these is kind of knowing your modes of transmission, kind of the parenteral, sexual, perinatal, etc. Some complications, I listed a lot here, but just think about immunosuppressants. HIV and AIDS are very similar to, the complications are very similar to the complications of a patient who's on immunosuppressants or someone that is having any sort of disease that affects the immune system. So they're at risk for more opportunistic infection. A big one for this is our wasting syndrome. So does anyone know what wasting syndrome is? Mm-hmm. Yep, Rosie. Awesome. It can also have, weight loss too. But just think about the cachexia, weight loss, diarrhea, malabsorption, anorexia, lesions, weight loss, etc. For these patients right now, our goal is to minimize exacerbations by preventing further infections, stress reductions, etc. A big thing for this disease is going to be our patient education on safe sex, using barriers, lubrication, condoms, dental dams, etc. With HIV, it is a notifiable disease, so they must tell their sexual partner of their HIV diagnosis. Also, I would go ahead and review some of the opportunistic infections and what they might present on and what they might look like as well. So our big goal for medical treatment is, while there is no cure, there is going to be, there's a lot more research going on with undetected being untransmissible. So again, our big goal is to decrease the viral load and really promote drug adherence up to 90%. We have our pre-exposure prophylaxis, which is going to be your Truvada. This is for patients that are at increased risk for HIV infection. They don't have HIV, but they might be exposed to it, whether it be a partner, whether it be jobs, etc., socioeconomic status. High-risk patients can be put on PrEP. However, it does take 4 days to start working, so keep that in mind. And they have to take it every day. You can also, if there's a potential exposure, especially like with our nurses, accidental needle sticks, etc., you can be started on a post-exposure prophylaxis within 3 days of exposure. The earlier, the better. And then that's going to be a couple different antibiotics. I have a whole slide on that. Again, we talked about treatment not curing, slowing replication. We can put them on CART therapy, NRTIs, and RTIs, etc. Really educating on modes of transmission, safe sex, etc. AIDS, on the other hand, is a status. So essentially, when the CD4 count dips below 200, the patient no longer has enough CD4 cells to fight any infection. So unfortunately, death is usually due to pneumonia, flu, etc., things like that. In order to have AIDS, the patient must be HIV positive, have that lowered CD4 count, and so opportunistic infections. Examples I included under the complications tab, so just kind of review those. And I also included some lab values for you guys. And because I love you and I care about you, I want to give a little bit of education on some accidental needle sticks. If you accidentally get stuck with a needle, you need to bleed the wound, you need to rinse that wound, and then report it to a employee health or occupational nurse after you've kind of rinsed the wound, and they will help you get connected on a post-exposure prophylactic therapy. Again, has to be within those 3 days. The sooner, the better. And just remember, whenever you're dealing with an HIV patient, they are under our normal standard precautions, which just are gloves. So I have one more practice question. This is about someone that is on immunosuppressants. They are HIV positive, status 3, which just means it's progressing. They haven't reached AIDS status yet, but they are immunocompromised. So which of the following will I educate my patient on to help avoid some of those opportunistic infections? Think opportunistic, rare. I really like this question. Do we want them changing cat boxes, litter boxes? Probably not. We don't want them changing litter boxes. There's a lot of bacteria that can be in cat feces that really is not good for someone immunocompromised. What do we think about avoiding cold or cool liquids? Do we think that's pertinent for an opportunistic infection? It might aggravate mucositis, but really not important for preventing an opportunistic infection. Do we want to make sure we've thoroughly cooked our animal products? It's probably a good idea. We do want to bathe with a nice antimicrobial soap. This one's a little tricky, wearing gloves when digging in the garden. We want them to avoid gardening, so not even gloves are going to help. They're really at risk for infection. Sufficient clothing in cold weather, again, not going to help with the opportunistic infections. Might prevent them from getting a head cold, but that's not opportunistic. We do want to make sure that we've washed our dishes. We also want to make sure that we clean the toothbrush, etc. So again, I put some of the answer choices here. Influenza vaccine. While it's important, vaccines will not prevent against opportunistic infections. So whenever you see immunocompromised individual, it's much more beyond just getting the flu. It is these rare infections, those Kaposi sarcomas, cytomegalovirus, things we don't typically see because usually our body's immune system is great enough to go ahead and prevent those. So that does conclude the end of this review. I am going to go ahead and stop the recording.